Welcome to the webinar on single-payer healthcare hosted by the League of Women Voters. This event is co-hosted by two local leagues, Eastern Upper Peninsula and Northern Lower Michigan. We are streaming this event to the League of Women Voters Eastern Upper Peninsula YouTube channel, where it is being recorded and retained for future viewing. The League of Women Voters is a nonpartisan political organization that encourages informed and active participation in government, works to increase understanding of major public policy issues, and influences public policy through education and advocacy. The League empowers voters and defends democracy. The League of Women Voters is an organization fully committed to diversity, equity, and inclusion in principle and in practice. Diversity, equity, and inclusion are central to the organization's current and future success in engaging all individuals, households, communities, and policymakers in creating a more perfect democracy. Anyone over the age of 16 is welcome to join the League of Women Voters, and membership for students is free. I'm Pat Freilich, a member of the League of Women Voters, Northern Lower Michigan. I'm a public health nurse with many years of experience advocating for social justice in healthcare and providing gap services for individuals who are uninsured or underinsured. I remember a woman who found a lump in her breast, but did not seek treatment because if I find out I have cancer, what difference does it make? I don't have any money for surgery or other treatment. It's better if I just don't know. I met with another woman with swelling on one side of her face, and when asked about it, she said, "There was a lot of pain in my tooth, but I'm thankful it is lessening." For most of us with access to healthcare, we would be immediately calling our provider to have our health issues addressed. Yet, for these women and thousands of others, healthcare is a luxury that they can't afford. So they live with the pain and the fear of the unknown. The United States spends twice as much per individual on healthcare, yet has worse outcomes. There are many possible contributing factors, ranging from the consolidation of hospitals, which leads to a lack of competition, to the administrative costs of about $940 per person, 4 times more than the average of other wealthy countries, and significantly more than we spend on preventative services or long-term health care. We know that copays, deductibles, and premiums continue to rise rapidly and are becoming less and less affordable. Even those with insurance avoid healthcare visits because of the high cost. Businesses have been forced to drop their insurance plans for their employees or cut pay increases in order to meet the premiums. The list of problems is a long one. So we all know that our healthcare system needs reform, and there are many proposals out there. Tonight, we will be focusing on single-payer healthcare systems. And now I would like to turn it over to our host, Megan.
Thank you so much, Pat, and thank you for sharing your personal stories as a public health nurse. I think that definitely is convincing if we weren't already convinced. I'm Megan Matajasic. I am a member of the League of Women Voters of the Eastern Upper Peninsula. We'd first like to highlight the healthcare position of the League of Women Voters. The official description is 3.5 pages long. So rather than reading all of that here, we're going to place a link in the chat, and that way you can read it, download it, and kind of take your time looking through it. And we have provided a link. Like I said, it'll be in your chat. And you can take a look at that when you'd like to. However, in a couple minutes, I am going to read a small portion of it, a summary. The League's National Board announced its original healthcare position in April 1993. So this is not a current issue. It's been looked at for a long time. While parts of the League position may appear in various single-payer proposals, the League currently does not support or oppose a specific single-payer proposal or legislation, including the Medicare for All Act of 2021, which has recently been introduced in the House of Representatives and calls for a government-funded single-payer system. Healthcare systems in the United States are complex, constituting 18% of our national GDP. The League position is written in a very broad language. The following summary is found in the official description that we have provided the link to. Financing and administration. The League favors a national health insurance plan financed through general taxes in place of individual insurance premiums. As the United States moves toward a national health insurance plan, an employer-based system of healthcare reform that provides universal access is acceptable to the League. The League supports administration of the U.S. healthcare system either by a combination of the private and public sectors or by a combination of federal, state, and/or regional government agencies. The League is opposed to a strictly private, market-based model of financing the healthcare system. The League is also opposed to the administration of the healthcare system solely by the private sector or the states. In addition to this summary, the League position calls for equity measures, allocations for those unable to pay, and for behavioral health measures, which we know are very important. Our main purpose tonight is to introduce voters to the concept of single payer. We sure do hear it a lot, but it's good to get a more in-depth introduction. And for more information, we do encourage everybody to do more research as they develop their own opinions. At this time, I am pleased to introduce tonight's expert and speaker, Molly Brennan, who represents Michigan for Single Payer Healthcare. Ms. Brennan has a master's degree in public health from the University of Michigan. She has worked in the nonprofit, public, and private sectors and has taught public health and healthcare administration. Her extensive resume includes at University of Michigan Flint, she served as lecturer and previous student internship coordinator, public health and health sciences. At Albion College, she was an associate director, Institute for Pre-Medical Professions and Health Sciences. She was a policy intervention specialist with the Department of Health and Human Services in Raleigh, North Carolina. She also held the title of program director with the American Heart Association Eastern Region and program director with the American Lung Association. She has worked as a senior healthcare analyst at Blue Cross Blue Shield of Michigan. She was also program innovation manager with Blue Cross Blue Shield of North Carolina. Ms. Brennan is also an educator, and she is here tonight to talk about single payer. Welcome, Molly. We're really happy to have you, and we're excited to be educated about single payer healthcare. We would like to give you time for your presentation and then allow time for questions and answers from our audience. We do encourage our audience to type their questions into the chat. Our monitors will select them and they will be read to Molly. If we can't get to all of your questions or if further research is required to answer a particular question, we will post the answers later to our Facebook pages so that people can see them there later. So without further ado, please begin, Molly.
Thank you very much. I'm absolutely thrilled to be here. And I'm going to share my PowerPoint now. Just need a second here. Here we go. Okay, and as Megan did indicate, if you have questions as we go along or things pop up that you would like us to discuss, please feel free to put that in the chat. So Medicare for All. This is what I'm obviously going to be talking about this evening. I'm going to talk about why we need it, what it is, and then we're going to open it up to questions and answers. I did want to, excuse me, share with you these three websites. They give some really good information about the Michigan for Single Payer Healthcare organization. You might want to access these if you're interested in doing a little bit more research on this issue for yourself. So this issue about healthcare being afforded to everybody has been around for a long time. On a global level, the World Health Organization came out with this quote through their constitution way back in 1946. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. On a more local level, in the United States, in March 25th, 1966, Martin Luther King Jr. famous quote, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." This was made, gosh, over 50 years ago now, this statement. And unfortunately, especially with COVID and the pandemic, we have seen health disparities underscored even more in our healthcare system. So the vision of single payer, a country in which all people can get the care they need regardless of how much money they have or do not have as a right. Some of this has already been touched on by some of the previous speakers, but I'm going to go through kind of where we are right now, where the problems are right now. And I'm highlighting some of the bigger issues around our healthcare system as it is now. This was already mentioned, but the US spends more than other industrialized countries on healthcare, and we also have worse outcomes. Our life expectancy is lower. Our infant mortality rates are higher, and our maternal mortality rates are higher, especially in communities of color. The United States is the only industrialized country without guaranteed universal health care of some kind. And despite the Affordable Care Act, 30 million Americans are still uninsured. That's a huge amount of people walking around without health insurance. 45,000 people die a year in the United States due to a lack of insurance, and another 41 million are underinsured. So they can't afford to use their insurance. And that could be a variety of issues why they can't do that. They may have really high deductibles. A really popular thing now in the healthcare insurance industry is high deductibles. So a person might have a deductible of $5,000, meaning they have to put out $5,000 before their health insurance even goes into effect. So when I'm sharing this kind of information with some of the students I teach, I say it's just like car insurance. You have a deductible. Say your deductible is $500 and you get into a fender bender. Before your insurance company will cover any part of the repairs to your car, you have to pay $500 out of pocket first. So being underinsured can mean a lot of things. One of them could be having a high deductible, maybe having really high co-pays. So it could be a variety of issues. This chart I wanted to share just because it shows life expectancy comparisons between the United States and other countries that have some form of single payer or universal health care. And you can see that we're trailing behind all of them. And as of now, we're sort of leveling off in terms of how long we live. And this number goes down again with communities of color, with minority communities. They don't live as long in our country. More of the problem continued. The system as it is now is not sustainable. Pat Freilich mentioned earlier that the GDP right now is almost 18% that we're spending on our health care. Just skipping down to that last bullet, you can see how much was spent on healthcare in 2019. It was 17.7%. Look at where that was in 1970. We were at 6.9%. 1990, we were 12.1. 2000, 12.6. We just keep going up. This is not a sustainable system. Healthcare cost growth refers to the rate at which the national spending is increasing. And some of the most recent, these aren't that recent, but this is the most recent figures that I had for 2013. There was a 3.6% increase. That was the lowest increase since 1960, but it's still more than double the 1.5% rate of inflation. So healthcare is becoming more and more expensive, and it's actually way ahead of our inflation rates. The GDP, this was from 2020, the U.S. Commerce Department's Bureau of Economic Analysis estimated for the second quarter gross domestic product showed healthcare spending climbed almost 5% to the second quarter a year ago. And the overall economy grew at a 2.3 rate in the quarter. So you can see healthcare is just outrunning all those other cost indicators. So we were at about $3.8 trillion in the United States in 2019 on healthcare spending, 11,582 per person. That's not per family, that's per person in 2019. And you can see that spending grew also for hospital care, physician and clinical costs, retail purchases of prescription drugs, etc. So the cost is running away from us, and it's not sustainable. Now, I mentioned this a few slides back, but the COVID pandemic has exposed the worst structural flaws in our healthcare system. Insurance is tied to employment. This is problematic on many, many levels, but because there were so many job losses because of COVID, people laid off, people let go, there was a lot of insurance loss. So the amount of people that are uninsured or underinsured just kind of skyrocketed because of the pandemic. And public health officials are anticipating what they're calling an afterwave of non-COVID deaths and hospitalizations as tens of millions delayed routine healthcare after losing their benefit. They didn't have money to go and get the medical care that they needed, so they didn't. Worse, and I'm sure most of us have heard this because it's been in the news quite a bit, worse COVID outcomes are for low-income Black and Brown communities. And this is theorized to be in part because of longstanding lack of routine health care. And this has just been exacerbated by the COVID pandemic. And we're finding that vaccines are being delivered where the pandemic isn't as bad, so in wealthier communities and whiter communities. A little bit more about the problem, kind of where we're at now. The average deductible for a person at this point is $1,350. A deductible meaning that's the amount of money you have to pay out of pocket first before you get any sort of coverage. That's average deductible. That means that there's people that pay less, but there's also people that pay more than that. 67% of bankruptcies are due to medical bills. A lot of people are financially strapped or in trouble because of their medical bills that they just aren't able to pay. 25% of Americans struggle to pay their medical bills outright. And this includes 20% of uninsured Americans. 42% of cancer patients lose all of their assets within 2 years of diagnosis. It's the last thing a person should be thinking about when they're sick and have a life-threatening illness is how am I going to pay my bills? The single largest category on GoFundMe is medical debt. People raising money to help friends, family pay for medical care. These were some tweets that people shared, and they wanted to share with everybody in terms of what happened with them and why they support the single payer system. I'm not going to go through and read all of these, but this really underscores the fact that people have real loss and have had real issues because they haven't been able to pay their medical bills. People have died because they have not been able to pay their medical bills or get medical care. And these are some of the more really heart-wrenching stories that have been shared. And to follow up with that, I'm just going to very briefly tell you what happened to me back in 2011. I was diagnosed with a benign brain tumor. And I want to really underscore the reason that I was diagnosed when I was because I had good health insurance. I went to an ENT and he said to me, I really don't think you have what's called an acoustic neuroma, but I'm going to give you a prescription for an MRI just in case you feel like doing it. I don't feel strongly if you have the MRI or not, because I really don't think it's it. The only reason I went to get that MRI is because I had good health insurance. MRIs are costly. They can be anywhere between $5,000 and $10,000 each for each section that the MRI is looking at. I did not have a copay. If I had any sort of copay, I probably wouldn't have got the MRI. If I had co-insurance, I probably would not have gotten the MRI. So I was told I needed brain surgery, hospitalization, inpatient occupational therapy, and physical therapy, followed by months of physical therapy. In addition to that, some other expenses that were all part of this: hearing aids, because I lost hearing in one ear, and specialized glasses. I had to purchase durable medical equipment, and I had follow-up appointments, and I have MRIs every other year to check my status. So the total cost for this, when I went back and looked at everything that my health insurance company covered, was almost $300,000. I consider myself lucky because I had health insurance through my employer. I had a job and I was able to get health insurance through this job. If people have jobs that are only part-time, if their employer doesn't offer them health insurance, they're not going to get health insurance. It's really expensive to pay for out of pocket outright just as an individual. I was able to take time off for my care. I had low deductibles and copays, very low. So it wasn't a financial burden to me. And I had resources, not just financial, to navigate this health crisis. I had support from friends and family, including access to medical professionals who are also friends. So I am not your typical person who was diagnosed with an illness that was quite serious and very expensive to take care of. I have a supportive partner who could drive me to all of my follow-up appointments and therapies and provide in-home support. I had good insurance. Because we get our insurance mostly through our employer, that limits people's choices for their jobs. So this goes beyond just looking at medical care, health insurance. I know people, and I'm sure that you know people, who have chosen their job because of what health insurance is provided to them. There's something fundamentally flawed with that. So the solution: single payer, universal health care, improved and expanded Medicare for all, the Medicare for All Act. It's been introduced as the Medicare for All Act of 2020 by Sanders and Jayapal. This would automatically enroll everyone. There would be no copays, no premiums, no deductibles, or other out-of-pocket costs. And the coverage includes vision, dental, hearing. It also would cover behavioral health, so mental health. As of now, the way our system is set up, you have to get a rider, or you have to pay more for vision or dental or hearing. And so those are just added expenses for people at this point. Through single payer, this would be covered: vision, dental, hearing. Also, long-term elder and disability care. We are living longer and there's more of us. The baby boomers are in that age now where, 65 and above, and are living for 20, 30 years beyond that. And so we're going to be needing more long-term and disability care. It will also include transportation to different healthcare services. And it'll really give us a nice cost containment, global budgeting, so to speak. And it will cut out the middleman, which right now is health insurance companies that drive up costs from 30 to 35%, purely on administration, not on any health care, on administrative costs. So improved and expanded Medicare for all. And there would be no duplication of services through private health insurance. Private health companies could offer supplemental plans. And there will be people that will take advantage of those supplemental plans if they want them. A single payer system would eliminate deductibles, co-pays, out-of-pocket expenses at the point of care while providing health care for all Americans. It also makes very, very good financial sense. Single payer Medicare for all will save the US between 2 and 5 trillion, that's TR, over the next decade. We're already spending almost 3 trillion a year on our healthcare now. And as I said, it is not sustainable. One of the questions that comes up quite often is how will it be funded? So let me just jump into this. First, recognizing that approximately 50% of US healthcare is currently funded through taxes, 50% through business and household pockets. And as I said before, most of us get our insurance through our employer. For example, I work for the University of Michigan. I get my health insurance through them. I pay a portion of it, and then the University of Michigan pays another portion of that. And it ends up being almost $18,000 a year, depending on what sort of program or insurance you get. A single payer system would be financed through a transfer of money that America and the country's employers currently pay insurance companies. Remember, 25 to 30% is now spent purely on administrative costs. Health insurance companies, marketing, putting through all the billing, all the paperwork. The premiums we pay now and employers pay now would be transferred to a federal program, which would be the single payer for healthcare services. The cost to all of us, either through taxes or out-of-pocket expenses, goes way down. Savings of over $700 billion per year. And this includes negotiation for prescription drugs, which I'm sure, as everybody knows, depending on what prescription drug you may or may not need, it can be extremely expensive. It can be completely out of reach for some people. There are some drugs that cost hundreds of dollars each month. And so the single payer system would really help to negotiate some of these costs down into a more reasonable amount. It's important to keep in mind that approximately 50% of US healthcare is currently public financed. We already have socialized medicine. We already have socialized programs, Medicare, Medicaid, the CHIP program. So when people say, oh, it's socialism, well, what I usually say is that we've already got social programs out there for us. So that's nothing new. So some of the pros of the universal healthcare system. Every provider in network. So in other words, you'll have more freedom. Anyone will have more freedom to choose providers, and there'll be more competition between providers. Right now in our healthcare system as it is, if you can only see certain physicians or healthcare providers that are in network. If they're out of network, you pay more to see them. Unions will no longer have to choose between wages and health benefits. Right now, it's a very tough choice for them because unions offer health benefits, very good health benefits to their workers, but a lot of times because it's constantly going up and increasing in price, they have to either decrease or freeze wages. It'll end job lock and create more entrepreneurship. Coverage would be continuous. You wouldn't lose coverage or need to change coverage when you change your job or your family status changes, your income, your state of residence. Right now, so many people are locked into their health insurance that is dictated by where they work. Equity, all US residents would have the same coverage. This would go a long way towards addressing racial, ethnic, and income-related disparities in coverage and access to care that we see now. And it's just the right thing to do. Healthcare is a right, not a privilege. Healthcare is a right. It's a basic human right. And so it's the correct thing to do. Some other pros. With all the providers and healthcare consumers in the same system, the potential to implement effective system-wide cost containment strategies increases. Again, this will be part of the cost savings. We could have lower health insurance, up to 60%, a 60% reduction in Michigan. Lower homeowners insurance and all forms of general liability insurance, such as workers' comp, malpractice, because this will end ambulance chasing. Doctors can focus on medicine again. Recent polls said that most doctors feel like they only practice medicine about 40% of the time. The other percent, they're doing a lot of administrative stuff. And they spend about $80,000 a year just going back and forth with the insurance companies. And doctors won't be forced to put through patient after patient after patient through the single payer system. They'll be able to spend more time with their patients because their pay is not being based on how many people they churn in and out of the system. There won't be surprise billing. If somebody's out of network and they don't realize they're out of network, especially in an emergency situation, there's not going to be a $1,000 bill that they get because they went out of network. Peace of mind, losing or changing jobs won't be so catastrophic anymore because you'll have that continuous coverage. Okay, that was kind of a quick and dirty about single payer, but I also wanted to really recommend Fix It, Healthcare at the Tipping Point. It's a really, really good documentary. It's less than an hour and it provides a really good overview of the single payer system. It's free. You can find it on YouTube. It's out there. So I would highly recommend, if you want to find out more about it, this is a really good show to watch.
Thank you so much, Molly. It occurred to me while I was listening to you share your own story, and the fact that Pat shared a story is every single one of us, if we don't have our own healthcare struggle story, we know someone who does. And I think that the ubiquity of that story should bring us all together in deciding that we need to do something about this. You know, and it certainly motivates me to be like, okay, when can I start making calls to my to my representatives about the 2021 bill being introduced? So thank you so much for the entire presentation and for your story. We're gonna start to look out there for some questions, and I'm gonna rely on Cami and Amy out there to see if we have any in the chat.
And I have one that's come in, and let's see. Here's a question. I heard that people have long wait times for healthcare in other countries. Would that happen here too? What if I needed a serious operation right away?
So if you don't have to wait long, if there's a serious issue, for sure. If there's an emergency, you're going to get right in. If there's, you know, if you have a brain tumor, you're going to get in. There may be wait times for elective surgeries or surgeries that aren't seen as, you know, life-saving surgeries. But in terms of care, when you need it, you're going to get it. If you're getting something elective, like maybe if you're having like plastic surgery or something like that done, there There could be a wait, but there's a wait a lot of times now in the United States. I mean, sometimes it takes months to get in to see specialists. So while there might be some waits for elective issues, when it comes to emergent issues or quality of life issues, no waits.
I have another question that came in. I had someone wrote, who's a teacher, I had my students debate this issue, and many of them read that doctors receive less compensation with single payer. Is that true?
It is not true, because of the savings that we're going to be having, because cutting out the middleman, that 25 to 35% being taken by health insurance companies right now. There's going to be plenty of money to allot appropriate salaries to healthcare providers, as it is now. So that's a misnomer. That's actually not true, and that's a very common question.
How will this affect businesses, especially small businesses?
How would it affect businesses, small businesses?
Yes.
Well, one of the things I think would be affected was that there wouldn't be so much pressure on small business owners to obviously be providing some sort of health insurance for their employees, because you're not going to have to do that. The taxes, any sort of business taxes will not be increased or anything of that sort to pay, so to speak, for the single payer system. If anything, I think it'll help small businesses, because I'm sure that some small businesses lose out on people because they're unable to offer insurance, or maybe they can't offer, high level insurance. So if anything, I see that helping, because there's not that pressure for small businesses to provide their employees health care.
Another question just came in that's more global in nature. How can the insurance company for-profit system be challenged? They used lobbyists to spread their myths.
Yeah, I mean, that's the $60,000 question, because they do have a very strong lobby. Blue Cross Blue Shield is one of the biggest lobbying arms right now. They put a lot of money towards trying to keep the system as it is. I think a big part of it is just, first of all, just educating people so that there's not so much misinformation about a single payer system or a universal health system. And there are more and more people coming out that have worked in the insurance companies that are now speaking out against it. There's a gentleman who used to be the CEO of Cigna. His name's Wendell Porter. He has now come out, written some books, done podcasts talking about some of the issues that really drove insurance companies. And part of that was actually putting out misinformation about the single payer system, so that people would be frightened of it, so that people would be scared of it. They didn't want to change that system. That's not an easy question to answer, but I think the system is being challenged now, just because more people are starting to be verbal about it. But that's something that we're going to have to continually do. We're going to continually have to reach out to politicians, legislators, and really provide the education around the fact that this is a good system, and this is going to be something really positive for the United States.
There's another question that just came in. Let me get a look at that real quick. Coming in from all at once. Is the healthcare for single payer system for all similar to what active duty military receive? We are active duty family and we really like the service, but there are some things that are not covered, like glasses and contacts. but we love it. Would all Americans have this kind of access with single payer?
I don't know if it's similar to what active duty military receive, but all Americans would receive, as I said, obviously, medical, but also vision, dental, hearing, behavioral health, so mental health, which is big, which we need, especially right now because of the pandemic. Those would all be included in single payer. So I wish I knew if it was similar or not to what active duty has right now, but I'm afraid I'm not.
Cami, do you have other questions coming in on your YouTube channel?
Yeah, I have one person saying that they've had an instance where, they went to the hospital and it was better that they had 2 or 3 different types of insurance because each covered part of it, and because nobody would cover all of anything. So why isn't it better to have multiple insurances?
Well, mostly because it's obviously going to be more expensive, and not everybody's going to have the option of having multiple insurances. Plus, with more insurances, there's more systems to navigate there, and again, you're getting a lot of money caught up into the administration, the bureaucracy of administration through the different insurances. So, I mean, right now in our system right now, that's great that you have 3 different levels. Not everybody has that availability or can afford having the 3 different insurances. With the single payer, obviously you wouldn't have to worry about things not being covered because pretty much everything is covered. And they're not going to be going to, health insurance companies that are saying, no, we're not going to cover that, or we don't feel like that's necessary treatment. That would not happen within the single payer system.
I have 2 more questions that are almost similar in nature. One is, how do we get unions on board? And the other one may be related. You might be able to answer them at the same time. In our partisan society, we've seen many attempts to work towards single payer. What would you suggest as a way for us to convince our representatives?
I know I'm going to sound like a broken record, but I think it's really reaching out and doing things just like this, presenting about what the single payer system is. I think there's a lot of misinformation out there about it. Like, for example, how do we get unions on board? Well, one of the things that I'm doing right now is reaching out to the union, because I'm part of the union at the University of Michigan. And I'm trying to set up time to go in there and do a presentation, because honestly, a lot people don't know about a lot of the ins and outs of the single payer system. They know some of the misinformation that's out there. So we have to keep educating people. We have to keep bringing it up as a topic. We have to put real information, accurate information and data out there, scientific data. And in my PowerPoint presentation, a lot of those sources were referenced, and those are credible sources. So if we keep doing that, I think at some level we're going to have success. It's going to catch on. And I think it's already started to catch on, that people are becoming a lot more now familiar with the single payer system and understanding that our system right now is not sustainable.
This is a great question, and I'm in healthcare, and I've heard this many times in discussions on this topic. How much would taxes go up for Americans? This is often a concern. People believe their taxes will go up.
Sure.
What would you say to that?
Well, your taxes won't go up. So this is what's going to, like right now, our system, the way it is, you pay a portion of your health insurance. Right now, like, let me use myself for an example. I get my insurance through the University of Michigan. I get Blue Cross Blue Shield. I pay a certain amount every month for that. I think it's around $500 every month. That's $6,000 right there out of pocket for me. That doesn't include my co-pays every time I go to see a provider or a specialist, I have to pay 20, 30, 40, 50 bucks. That doesn't include the money that I pay for my co-pays for prescription medications. So I already pay a lot out of pocket for health insurance and for all the things that come around with that. The taxes won't go up because we're going to be saving so much on an individual level with how much you pay for your health insurance, deductibles, co-pays, covering things that aren't covered. And because we're cutting out the middleman, which is all the health insurance companies, and there's hundreds out there. There's a few big ones that we all know of, but there's literally hundreds of different companies out there and hundreds of different plans for people. And they all are part of the administrative bureaucracy, where we're going to be cutting away from all of that monetary waste, really, on administration. So the taxes will not be going up, but you're going to see savings in other areas, especially for yourself or your family.
We have a comment here from a listener who just noted that police officers would be able to get people mental health help instead of sending them to jail.
You know, and I think that's a really great and important issue for us to look at, because even up until 10, 15, 20 years ago, there was very, very poor coverage for mental health. And there still isn't great coverage in some areas. Some people still only get 50% of mental health coverage. And that's something that we really need to focus on, because we're seeing how much we need that, particularly through the pandemic. Mental health is critical in terms of making our society stronger and healthier. And that's a great point that, you know, police officers, law enforcement could refer people out for mental health, because that's going to be obviously covered for everybody under single payer.
Cami, how's it going on the YouTube channel?
Not a high amount of chatter, but how well then do you think that the government will be able to negotiate with the drug companies to regulate or keep lower prices on some of the medications?
Well, if we go to a single payer system, they're not going to, the ball is going to be a little bit more in our court, so to speak, and less in the pharmaceutical court. We will have, if we go to a single payer system, we'll have more negotiating power, because we're going to be calling the shots, and the pharmaceuticals won't be calling the shots at this point. I think right now the VA actually negotiates with pharmaceutical companies, and they have put caps on how much medications can actually cost. And the pharmaceutical industry has worked with them for years on this. And so I think we would just be doing it at a larger, bigger scale if we went single payer for all.
Here's a question that applies to seniors. Do you know if Medicare Advantage would go away with a single payer system? We pay 10% more in administrative costs for Medicare Advantage plans, which pays for for-profit insurance.
Okay, that's a good question. I'm not absolutely sure, but I do know that when we do go to single payer, which I think eventually we will, it might not be tomorrow or 5 years from now, but I think we eventually will. Everybody will have the option to still supplement their healthcare policies with private insurers, but I don't know about Medicare for all. That's a really good question. It's something I can certainly find out. Are there other questions or other things that people would like to discuss?
I have one more question here about our rural hospitals. You know, in northern Michigan and other rural places, we've got smaller hospitals. Would a single payer system, what would happen to our hospitals up here? The question is, would they cause us to lose our rural hospitals and healthcare providers?
You would not lose rural hospitals because obviously they're critical to have. So I don't see that happening with a single payer system because there would be no need for the rural hospitals to go away. With the payment schedule changing drastically as it would actually, I would be surprised even if there wasn't some new developments for maybe possibly more urgent cares or something like that, but I do not see hospitals going away at all.
Do you envision that specialists would be more spread out? Right now, they tend to be concentrated with cities. But if perhaps there was some sort of guaranteed payment, do you think there'd be more specialists available in the rural areas?
I think that there actually would be, yeah, because as you had mentioned, they're really kind of clustered right now in bigger metropolitan areas because that's where they're going to get, individuals coming. But I do see there being more availability to specialists in smaller communities through the single payer.
Molly, there's a question here. Do we have any idea of savings for city, township, and county governments if we enact Medicaid for all? Would that provide a substantial savings for local governments and taxpayers?
That's a good question. I would think that it would, because right now the city, township, county government officials all have to get their health insurance through the city or the county. And so I do see it actually saving money in that sense. I don't know what that would look like in terms of percentage or anything like that, but I do see it as a savings because, again, they wouldn't be going through the middleman and there wouldn't be all that money wasted on administrative issues.
In addition to administrative cost savings, what other cost savings would we generate by having a single payer system?
That's a good question. One of the things that I can say is that because right now healthcare providers and health systems are paid by the amount of people that are put through the system, that I think there would be cost savings in terms of not running maybe unnecessary tests. Not a lot of times, but unfortunately, the way the system is set up now, if you run, more tests for somebody in particular, there's going to be obviously higher reimbursement. I don't think a lot of healthcare providers do that, but there probably is some. Also, through the single payer, physicians, healthcare providers are going to be able to spend more time with their patients, not like a 10-minute office visit. They're going to be able to look at complex cases, people who have, a lot of comorbidities, and really be able to work with that patient for more than 10 minutes. And therefore, that would be helping the health status of not just people, but communities. But in terms of specific other cost-saving measures, other than administrative, which is huge, I don't know off the top of my head, but again, that's something that I could find out because I know that there's other cost savings out there.
Thank you.
Here's a question from a viewer who is asking a really good question. Is this insurance run by the government, or is it healthcare run by the government? Would we have many government insurance plans? Would this be a growth on the ACA exchange?
It would be, I don't have all the answers to that because I don't know exactly how it would be implemented. It would be there would be some components, some factors of the ACA would be part of it, but like the prevention and kind of wellness aspects of healthcare, which the ACA has now kind of brought into, preventative measures, pap smears, vaccinations, et cetera, things like that. I don't know exactly how it would be set up and run or who would be doing that, but I would imagine that it's going to be multiple players. And it's not going to be like just a government run system per se. I'm sure, I don't think that answers the question as well as I could, but again, that's something that I could find out more about.
We have a question about medical records. Would a Medicare for All system establish a national record system? And would that make it easier to treat Americans and call up their medical history?
Yeah, and I mean, that's kind of how it's supposed to be now, and we all know that that's not how it is, unfortunately. One of the things that Obamacare was really looking for was really to get everybody streamlined through electronic medical records, so that if you went to one hospital in one state, they could still pull up your record if you ended up, if you're on vacation and you had to go to another hospital somewhere. I do think the single payer system, it would be, first of all, it'd be a lot easier to probably streamline that process. But yes, that is something that they would be looking at implementing fully, because the Affordable Care Act put a lot of money towards that, but it's still very piecemeal, and there's still a lot of issues with that system, and that needs to be improved and corrected.
It is coming up on 8 o'clock. Before we sign off, I obviously want to thank you, Molly, very, very much for helping us to learn more about single payer healthcare. If we find that there's more questions in the chat that were not answered, the League will make a point of answering them later in a post or comment on our Facebook pages. Our thanks to everyone who made this webinar possible, and our partners in Northern Lower Michigan, and to our audience for listening and asking great questions. I am going to put a couple more links in the chat because I happen to be looking for myself. I wanted that PowerPoint with all of those reliable links. So I've put in the link to Michigan for single payer, and then the slides are available as well, because I was just like, had a hankering to get at those links. And Molly, something that you said means a lot to me, because I got my master's in information science at U of M. So reliable information, particularly reliable health information, can go a long way towards encouraging people to trust these types of plans and not getting bogged down by some of the misinformation. So thank you very much for providing reliable healthcare links, and also for making that a priority. And everybody here, we hope that you have learned more about what single payer means. We encourage you to do more research. Ask your librarian if you need some help. And thanks again for joining us for this very important topic. And Molly, thank you so much. It's just wonderful information, and thank you for the work that you do.
You're very welcome. And my email and I think my phone number is on there too. If anybody wants to talk more or just shoot around some ideas, please feel free to reach out to me. Always happy to talk about it.
Fantastic. Thank you so much. Good night, everybody.